Good afternoon. Looks like I'm the last person that is standing between you guys and the train, or you all in your mode of transportation. So I'm Dr. Asa Briggs. I'm actually a psychiatric nurse practitioner, and I came all the way from South Carolina today. So I'm going to take my time. I think this is also telling that mental health is oftentimes the stepchild in the room. So maybe next year we can change the order of operation and put mental health woven into the other presentations. So that's just my little soapbox. I don't have any disclosures this afternoon, so I'm going to get right into it. Really looking at the significance of culturally informed care for vulnerable populations with mental illness. Let's see. All right. So here are the objectives for my talk: to understand the impact of mental health challenges, explore barriers to mental health care, highlight the need for contextualized models of care, and then lastly, encourage vulnerability and transparency in healing. I typically don't read from my slides, but I feel like I should at least try to look at my slides this afternoon because I think this is such an important topic, and I want to bring gravity to this conversation, even though we are at the end of the day. Looking at prevalence of any mental illness in America, in 2020, there were an estimated 52.9 million adults aged 18 or older in the United States with any mental illness. And this number represents about 21% of all adults in the U.S. And the prevalence of any mental illness was higher amongst females than males. And then young adults aged 18 to 25 years had the highest prevalence of AMI at 30.6% compared to adults aged 26 to 49 at 25.3 and age 50 and older at 14.5. I can anecdotally say that some of the data that is bared out here with 18 to 25-year-olds would be COVID-19 and social isolation. So I think about that a lot. I see that now in my care, especially with this population, because they spent most of their formative years in isolation. So we're seeing a lot of deleterious impact and changes in the mental health of that individual population. Looking at the prevalence of AMI was highest amongst adults reporting 2 or more races, followed by white adults at 22.6%, and the prevalence of AMI was lowest amongst Asian adults. Maybe they have the secret sauce, so we need to talk about that. Mental health services for AMI. In 2020, amongst the 52.9 million adults with AMI, 24.3 million, 46% received mental health services in the past year. So this is really telling of the dearth of resources in our community. I think this is also very problematic for us as we think about the topography and the changes of mental health and the crisis that we're currently experiencing. I think that as we sort of encourage people to come into the healthcare arena, we need to really think about individuals who are interested in mental health and behavioral health. Some of the disparities that we notice with individuals who identify as African American or people of color, oftentimes they come into a system, and I say a lot in my talks, is that racism, sexism, and the like don't stop because you put on a white coat or that you put on scrubs. I think those nuances, those presuppositions that you have about the people that you serve, it doesn't stop because you come into a clinical setting. And so looking at the impact that, as many individuals have said before me, that racism has on individuals in the healthcare system. Mental health services is no different. So actually, individuals who identify as African Americans are oftentimes looked at as less likely to understand medical information, so therefore their providers don't give them evidence-based practice. That is very harmful to the individual. Oftentimes, they are throwing everything at this individual, really messing up opportunities for them to continue in mental health services, because oftentimes these people don't come in to care but once, and then they see that cultural competency, which is a word that has been thrown around a lot today, but dare I say cultural competency often looks like the perpetuation of stereotypes. So I love the idea of cultural humility and cultural safety, meaning that you don't look at, as Dr. Hawthorne said, is that you don't look at individuals from marginalized communities as the exotic other. You don't want to look at them as being the problem, but thinking about the ways in which your culture has exacerbated the symptoms that these individuals are presenting in the clinical setting. Oftentimes, African Americans are overdiagnosed with schizophrenia and bipolar disorder, which carry a more, stigmatized label, if you will. Oftentimes, this puts individuals at jeopardy of not being able to go into the workforce, not be able to stay in public housing, and really sort of perpetuate some of those social determinants of health and health outcomes. Looking at opioid use and illicit drug use, the African American community is slightly higher than the average, with rates of alcohol use slightly lower than the national average, including heavier drinking and binge drinking. So again, thinking about the fact that African Americans are not studied in the literature, oftentimes the things that we're asked to do from a clinical guideline perspective have not been studied in the population because context does matter. So I love the fact that Ms. Miller before me said that oftentimes we're looking at individuals from a lens of pathology and we're assigning pathology where there isn't any. And so that is really sort of one of the things that I think that in the South in particular, when you think about racism and you think about redlining and housing and things of that nature, is that people have been pushed to the margin. And later on in my talk, I'm going to talk about marginalization as a means of understanding why people are mentally ill and physically ill. I think I talked through that. Health-seeking behaviors, really important for us to understand. I love how Dr. Beverly talked about this morning, the patient that she had that didn't want to miss church. In the South, everybody is cultural Christians. I mean, it just happens. It's in our DNA. And one of the things that I'm doing in regards to that is really reaching out to the churches and looking at community-based interventions for individuals who come from marginalized communities. Pastors and church leaders are oftentimes the individuals who give people permission to talk about mental health and the disparities of inequities in healthcare. And so I think one of the things that we need to talk about is religious ridicule as it relates to health and health outcomes for marginalized communities. And then lastly, oftentimes African Americans are individuals who identify themselves as people of color, oftentimes talk about their mental health challenges with their primary care providers. And so part of my work is to inform primary care providers on best practice and evidence-based standards for individuals from marginalized communities. Thinking about the barriers, oftentimes I hear people say they don't have adequate transportation. We understand that there's an administration now that is really working to minimize and to get rid of a lot of the Medicaid, Medicare services. And so individuals who were once given access to mental health services are now having to go to the ER, emergency rooms, et cetera. And so I think that what we need to do is make sure that we advocate for those individuals and advocate for the healthcare system to not get rid of Medicaid, Medicare in the way that it is projecting, because I know that where I live, Medicaid, Medicare is the number one provider of healthcare services in rural South Carolina. So the impact of what I'm seeing in the administration is very heavy for me. In terms of lack of transportation, inconveniences, I hold longer hours in my clinical practice because I understand that people don't have the privilege of going to the doctor during the day. So I stay open sometimes 7:30, 8 o'clock in the evening, just to make sure that I lower any barriers of access to care for these individuals. In terms of stigma, I think I've talked about that. One of the things that we need to think through is perceived ineffectiveness. Oftentimes, because people are not used to being heard or have agency in these kinds of conversations, they don't believe that mental health clinicians really care about what they're going through. And subsequently, they withhold a lot of the information during our intake process that will really be beneficial in their health and health outcomes. I just spoke briefly about this earlier, and I'll mention it again. Marginalization really uncovers health implications and social ramifications based on the magnitude of marginality. And so the intersection of marginalization and social determinants of health defines one's health, one's social position, and it links the two variables together. So marginalization really sort of helps us to understand that we talk about food deserts. Deserts are actually natural occurrences. I love the language of food apartheid. I know that this is not a novel statement here in New York City, but as we think about grocery stores that are closing down and lack of resources in the South, people want to call things deserts. And I'm like, no, these are intentional systemic issues, and people are intentionally closing these things down and putting us at greater risk of poor health outcomes. Thinking about steps toward health equity in diverse cultures, we need to understand, I love the fact that Ms. Miller talked about not one size fits all. So engaging in communities that live at the margins to hear what they have to say about mental health services. How do they engage their mentally ill? What do they think about those things culturally, religiously, et cetera? We need to do a better job of doing community assessments. Oftentimes we're going into communities and we're implementing programs that have not gotten the necessary approval or the stakeholder buy-in to make sure that these programs are sustainable. Training, again, the dearth of psychiatric services, the gap of psychiatric providers that are coming into the healthcare system are continuing to grow year after year. And so we're seeing medical schools that are not recruiting or medical students who are not interested in psychiatry. Same as for nurse practitioners and physician's assistants. So we got to do something in terms of our training. And then when we train them, again, going back to the cultural competency that we've talked about, we need to think about cultural safety and cultural humility. And then acknowledging the fact that marginalized individuals have been impacted by majority culture. And so when you acknowledge that your culture is implicit in some of the things that are showing up as pathology as you are assigning it, it really sort of changes the conversation for the individuals. Community mental health and reducing disparities. The Biden-Harris administration in fiscal year 2022 really invested in community mental health centers and community-based interventions. And so now we have an administration that is actually rolling a lot of that back. I think in Alabama it was overnight there was a NIH grant of upwards of $10 million or so. And so individuals came to work in community-based mental health centers and were turned away and subsequently had patients that were abandoned and lost to care overnight. So these things are happening, and they're happening in real time, especially in the South. Thinking about contextualized models of care, we have to move away from this idea that one size fits all. So we have to think about ways in which, and this is particularly important for African American men and how we show up. Healing circles are cost effective. Thinking about ways in which we are not thinking of ourselves as individuals oftentimes when it comes to mental health, because you don't want to be perceived as crazy. You don't want to be perceived as having an illness that other people are going to stigmatize you or further push you into the margins. So thinking about ways in which people can come together collectively and heal collectively from the collective traumas of America. So I heard that this conference was held in Haiti, and so I had the opportunity to go, I think it was like 8 years ago, because one of the things that I'm very interested in is the globalization of contextualized models of healthcare. And so I had an opportunity with 2 other providers from Notre Dame to hold what we believe to be one of the first psychiatric clinics in Haiti. And this place is in Léogâne, and this young lady here is holding a plant and talking about healing practices. She has understood that oftentimes big pharma doesn't come into places like Haiti. And when they do, they drop off medications that are not sustainable and continuity, and they don't really ask the questions of what have we done to make sure that we take care of those individuals who are mentally ill. And so there are a lot of herbs and a lot of things that we're putting into our bodies that are not helpful to our mental health. And so this young lady was very keen about the things that were available readily to treat people with psychiatric illness. And that is something that I encourage as I was there, because we had Prozac that we had brought over from America and Trazodone and things of those nature. But when that medication runs out, what do? We started treatment, and then we've left that patient to their own devices. And so working in collaboration with the local healers and the people who have been doing this work, I think is very, very important. And look at, this was a line that came, it went off of the picture. And people were walking for miles and miles and miles to talk to us. And we stayed there for 5 days, and I promise you, we saw over 800 patients, some of whom we could help and some of whom we could not, because the acuity level of the patients' presentations was such that we had to help them to get to the only inpatient psychiatric hospital, which was Mars Klein in Port-au-Prince. So we really are fortunate in this country to have access to some of the best inpatient and outpatient ambulatory services for psychiatry, because when I look at this picture, I'm reminded of the fact that not everyone has that. This was some of the nursing students. Also very keen, I'm also very, you guys are awake now. I'm also very keen on the fact that indigenous people need to be serving people from their countries. I don't think that Western philosophy needs to be overlaid in cultures where we don't belong. And so one of the things that we were working on was trying to get certification for nurse practitioners to provide psychiatric services to the folks that we were seeing for continuity of care purposes. Unfortunately, due to the increased rates of suicide, we were unable to continue. Notre Dame did not want to continue that program with the liability of the increase in suicide. So here are my references, and thank you guys for allowing me to talk a little bit longer. Yeah. So.